discussions on One Health center around diseases. Health is not only about diseases. Well, let me start by telling you a story. Rani, I'll call her Rani, that's not her real name, was a tsunami orphan in our neighboring state. She and her younger brother grew up on the street. When we met her virtually, she was 16. She, unfortunately, at that age, had got cancer of the right thigh bone. The swelling grew. Naturally, she didn't access good health care. It grew and it started fungating. She was in agonizing pain and there were maggots crawling over it and the whole ward was smelling. And when a whole ward smells in a government hospital, what's the action? One evening, she was taken out of the hospital, discharged, and put on the sidewalk outside the hospital, one of the best known hospitals in the country. A passerby, an alternative medicine doctor, was also a human being. He couldn't bear the sight. He put her in his car and took her to his clinic where he kept her. And he wrote emails to all palliative care people in the country that he knew. And we got one of the emails. We have collaborators working in that city, which I will not name because I don't want to name the institution. And a kind community medicine doctor for whom I have such great respect, and a medical student took an ambulance on a Saturday, the next Saturday, went in search of her. She had been moved to a so-called terminal care home run by a church. They were very kind to her, but they had no facility for pain relief. They couldn't do anything about the maggots crawling over her body and soul. This doctor had taken morphine with him. Her pain was treated. And she was transformed to another person. She started calling the doctor uncle and the medical student Anna. They were driving to a palliative care center which had accepted to take her in Chennai, which had accepted to take her in. Anna, stop. She wanted a Fanta and a snack. They stopped. She got the Fanta. Got to the palliative care center. I'll cut short the story, summarize, where she was put in a room. In 2 days, they could take care of the maggots. Maggots are not convenient. That's not interesting. Unless you have expensive technology to make a diagnosis, not interesting. Well, she wanted to see television. A television from the common room was brought to her room. There was a vegetarian hospice. She wanted chicken. She ordered chicken for 2 meals every day. She had it. And then came the request. She wanted 2 things. She wanted to see her brother again. Younger brother who was only 14 was working for ocean fishing. Once he goes, he'll come back only in 14 days. She couldn't see her brother again. But she had another wish. She wanted to see the sea again. She wanted to go to a beach. When she was very ill, she was taken finally to see the sea again, where she had grown up, where the worst calamity of her life happened. She died 6 days after reaching that place. I am very proud of the doctors and other staff who cared for her as a human being. If we talk about One Health, human health, animal health, environmental health, all together, we have to first think about what health is. This is official definition of the World Health Organization, which is almost as old as myself, never changed. It is physical, social and mental well-being. It is not only absence of diseases, not merely absence of disease or infirmity, and we forget it. We are in palliative care, people who talk about wellness, well-being. We take care of suffering, the maggots, the pain, and we create well-being by physical, social and mental well-being, which included treating her with love for the 6 days and taking her to the beach where she was feeling connected again before she left this world. If we are to get to that One Health destination, our current railway track which will lead through hospitals will not be enough. Because we need physical, social and mental well-being. In India, less than 4% of people have access to the pain relief that Rani finally in the last days could access. We need that. But we also need that social, emotional and spiritual. I don't necessarily mean God or religion. Meaning of life. Feeling connected. That matters. My own professor, medical college, after many years after his retirement, died 2 years back. He had a dementia. Rani got good care. I believe my professor did not. When he stopped following international guidelines, said don't put in a tube, but he had to put in a tube to feed. It was important. Nutrition was important. And because she would pull the tube out, they bound her hand and feet. And once that happens, agitation increases 44 times, as data have shown. And she was violent, bound harder, which meant in 2 days her whole back was ridden, his whole back was ridden with pressure sores. And eventually, his respiration was supported. Oh my God. The one prayer that I have is that kind of thing shouldn't happen to me. At least when I am leaving this world, I hope I will be treated with some dignity. Well, the doctor eventually told me this was a man who gave a lot of love to others during his life. He did not deserve to go this way. She had actually talked to the doctors, please stop this artificial ventilation, but they said, what do you mean? What else can we do if the oxygen drops? She couldn't answer that question. This is what we are talking about, palliative care. Treatment of suffering and improving the quality of care. And the World Health Organization 10 years back recommended that this is to be integrated into all healthcare. Any healthcare, acid-treated diseases should also take care of this. This means well-being. Dr. Mr. Rajgopal is our CEO of our organization, and he did not have to do anything about it. The human beings working there did. They take in stray dogs if they wander in, and they sterilize them, they vaccinate them, and they become part of the team. And the kind of good that they can do for patients, lonely people, is phenomenal. The middle picture shows the boy who was our patient, and he adopted one of the stray dogs and went home. And I personally believe that the dog did more for that child than any of our sophisticated treatment. How do we do this? Because of you. The fact that you have invited me to here to talk about it itself shows that you are part of this. The Global Astana Declaration says health for all can only be health with all. Doctors, nurses and hospitals alone cannot do it. The community has to be involved. Whatever we do because the community gets involved. And that's how One Health can be achieved. Integration of the environmental health, animal health and human health, which means physical, social and mental well-being. And I'll stop by showing that picture. I don't know whether you will consider that healthcare. That one of the women on wheelchair once said she wanted to see the sea. She had seen the sea as a child. She wanted to go to the beach again. That World Palliative Care Day in October 2nd Saturday, about 160 engineering college students got together, 4 to 1 patient, transported them, physically picked them up because we do not have wheelchair-friendly beaches. And they went there, and you can see that girl in green and red actually holding on to the neighbor's hand just to share the joy. And she is paraplegic. She does not have normal sensation on her feet. And she said, the waves touching my feet was the best experience that I have had in my whole life. Isn't that the height of healthcare? And it was done by ordinary human beings. So I'll stop there with leaving this question with you. Yes, what are we going to do about it? What I hope will happen is that this subject will be discussed before we leave this hall this evening. There may be, in this group, I am sure there will be at least 20 people who feel I would like to do something to help, to do a bit of volunteering, to bring a little sunshine to people. Let us get together. Rajgopal and colleagues will organize everything. We can do some awareness programs and volunteers training, maybe on that Saturday. When you have some time, some people can actually pitch in. Because we, doctors, nurses and medical social workers and physiotherapists do only 1/4 of the work. The rest will be done by the community. Thank you very much for listening to me patiently.
Thank you, sir. I'd like to now call upon our next speaker, Dr. E. Sreekumar. Dr. Sreekumar is a virologist and currently the director of Institute of Advanced Virology, Tirunelveli. His laboratory in Rajiv Gandhi Center for Biotechnology, where he served as a scientist for 18 years before moving to IAV, played a key role in initiating molecular viral diagnostic services in Kerala. He's a recipient of the Fulbright Nehru Professional and Academic Excellence Fellowship in 2015 and was a visiting faculty in the Johns Hopkins Bloomberg School of Public Health, Baltimore, USA. He has major research interests in identifying broad-spectrum antivirals using host-targeted approaches. His team at IAV has initiated programs on bacteriophage-based approaches in tackling antimicrobial resistance and monoclonal antibody development, and also metagenomics-based approaches in virus discovery. We're waiting to hear from you, sir.
Good morning. First of all, let me thank the organizers, especially Sri Padma for inviting me for this program, and extremely happy to be part of the On Health discussion today. So, let me go touch a little bit on the basics before we get into the actual picture. The concept of On Medicine to On Health. So it is a very old concept, even though in the 1960s, one of the veterinary epidemiologists and parasitologist, Dr. Calvin Schwab, he proposed the concept of On Medicine. So here you don't see the word On Health, it is only one medicine, where it's only between human and animal, those diseases which are transmitted and through the interaction. But slowly what we see is in the 21st century, in 2004, when the Manhattan Principles were promulgated, a more integrated view came in, and we could see the term has changed from On Medicine to On Health with the inclusion of the environment component into that. So the definition became human health is intricately connected to those of other animals, plants and environment that they inhabit. And when the SARS-CoV-2 epidemic started, we started talking, but I'm not talking about the second source, the first source started. So we started talking more on this on health. So we started thinking that okay, animals spillover infections are becoming more frequent, and this became we could see that literature started coming on in the name of On Health. Journals started coming in, and this became more consolidated with the onset of COVID. And one more new thing came up, that is climate change, and how this is promulgating or this is contributing to the spillover infections. Then Sustainable Development Goals defined on health as one of the major target, and there is an on health quadripartite where World Health Organization, World Organization of Animal Health, United Nations Food and Agriculture Organization and UNEP started defining or making it more consolidated and more structured the One Health program. And there were 6 areas primarily identified in the One Health: the zoonotic diseases, neglected tropical diseases, antimicrobial resistance, food safety, environmental health, and laboratory services. And though I have put laboratory services in the last, later on you would see that is the most important in making the One Health really happen in the field level. Now, zoonotic diseases, if you look at the 21st century viral diseases that so many diseases have been spilled over or new outbreaks we have seen, and almost 75 to 80% of them had an animal source. So that itself made more important that the zoonotic diseases are there, and it is going to be there, and it will be one of the reason for the new disease which is predicted, or a pandemic that is predicted, that is pandemic X. So we thought that COVID-19 would be the pandemic X, but we still think that it is not the pandemic, something more worse is yet to come. So that is really, really dreadful to the human population. Now again, along with these viruses, there are many other neglected tropical diseases which include bacterial diseases, fungal diseases and parasites, and also even snake bites, which all been included as a neglected tropical diseases by WHO. And the One Health paradigm is supposed to focus on all these diseases to make the health of the population in a better way. I don't need to speak more on these diseases which I am going to talk about now. I'll just glimpse through all these. So just to get a flavor of the current problems that we are facing, chikungunya and dengue, definitely all people in India know very well about chikungunya and dengue. We have been suffering, or we have suffered a lot of outbreaks of chikungunya and dengue. Personally, I have some interest in these two viruses with which I have been working for last about 20 years. And then coming to the Japanese encephalitis and West Nile, and recently we have heard about the West Nile infections that is happening in Kerala. And still its confirmation of the disease becomes challenging because of the lack of proper diagnostic tests and cross-reactivity between different viruses in the same group. And we have the Kaisanur forest disease in Shimoga and adjoining areas and some part of Kerala. There are cases of Kaisanur forest disease reported, and even few mortality. And this is considered as an emerging infection as the tick population is present throughout the Western Ghats, and it can spread from one corner to the other. Then Crimean Congo hemorrhagic fever, we had outbreaks in small cases in India. Which not in Kerala especially, but suspected cases or exposed people were brought to Kerala at that time, and we were worried about some cases in Kerala also, but fortunately we didn't have many cases of Crimean Congo hemorrhagic fever in India. Now hantavirus is one virus which is still not confirmed by the virologists or the clinicians in the country, but it is highly suspected that hantavirus is circulating. A long time back there was one hantavirus which was discovered called Pallium virus, but later on the activity of this hantavirus is not confirmed in the patients. But H5N1 influenza, we have been getting cases. Even now if you go to Alleppey, you can see ducks are being culled and frequent infections. Unfortunately, even within the H5N1, the highly pathogenic variant which may have the chance to spill over to the human population, it has not been reported so far. But anytime that kind of a change can happen in this particular virus, because this is a highly mutating RNA virus. Now coronavirus, we have been talking about SARS-CoV-2, SARS-CoV-1, MERS-CoV-2, and see if you look at the literature, you will see that in the virus in the bats, there are around 3,000 odd sequences which is similar to coronavirus family members. Maybe there are 3,000 viruses, or maybe these are parts of the same viruses that they could detect by the metagenomic virus discovery approaches. That means there is a lot of things in waiting in the bats and other animals that can spill over to the human population. So the pangolins and bats and other intermediaries which many people consume them as part of the exotic or wildlife tourism, and also get into their habitats, and they may get infected with these infections. Nipah virus, I don't need to tell this audience about Nipah virus. We have seen multiple outbreaks of Nipah virus, and initial were much more mortality. Unfortunately, the last one we could at least save some patients in the last outbreak. But there are still chances of Nipah virus spillover infections happening, and still we could not identify the actual interface where the spillover happens. So that is one lacuna where we cannot do the actual control measures. Ebola, fortunately, it's a high mortality disease. Fortunately, we are still safe from Ebola. But we don't know, like this is also a threatening disease to the country. So these are all unhealth pathogens which can spill over to the human population anytime. And among the other areas which has been stressed by the quadripartite, I will not stress on the antimicrobial resistance or food safety. I think others would have covered on this. But I will just touch upon this environment health in the pathogen aspect. See, we know that climate change is increasingly a significant factor in the public health. And there are direct effects of temperature which we have been seeing, the heat stress and all the sunstrokes and all the kind of things we have been seeing. But indirect effects like water shortage, food availability, altered rain pattern, and which can lead to waterborne diseases. We have been seeing a hepatitis outbreak in the Malappuram area. Definitely it might have a connection with the drought or the scarcity of water which has been prevailing in the region. So apart from that, these altered climatic change, I think in the previous discussion we could see the temperature increases the virulence of the pathogens, and that was especially mentioned for the bacterial pathogens or others. But we have done some studies and we could see that changes in pathogens, especially changes in the disease vectors and the virulence of the pathogens can happen. Recently we published a paper wherein we could see that when you grow the dengue virus at a higher temperature, usually in the mosquitoes we grow the virus in a temperature of about 28 degree like that. But if you force this virus to grow at a higher temperature like a 35 degree or so, you could see that more virulent viruses are coming up. In an animal model we could see that there is an increased mortality, increased severity of the disease. So that directly tells us that an increased environmental temperature can alter the virulence of these viruses. So when you have dengue or other vector-borne diseases during high climatic temperature conditions, maybe we don't see the same pattern that happened in the previous time. Maybe we'll be seeing more severe infections. So definitely climate change is going to alter the severity of most of these viral infections as well. Now, when we speak about the spillover infections that is happening from animals to human beings, it does not happen overnight. There are different stages, but in some cases we don't see the spillover. The time, the gap will be very limited, like what happened during the SARS-CoV-2 because of the high epidemic potential of the virus. But in other cases, it might be a slow activity. But in such situation, the early detection, what is happening, whether this is present in the animals and whether the first time of spillover has happened, these are the times where we can control these infections. So, in implementing on-health and pandemic preparedness in Kerala, there is an essential need for a political will and a robust public health system. Fortunately, compared to many other states in the country, we are much better off. We have political will, we have a robust public health system. But one of our challenges is the Western Ghat ecosystem. Western Ghat is the one that makes Kerala. And Western Ghat is the challenger, the same Western Ghat offers huge challenges for the health system of within Kerala. And there are suspicions or reports which indirectly points out that Western Ghat is the source of so many viruses and other unknown pathogens that is spreading into the population. And maybe if you look at the literature of dengue, there are reports which anecdotally which says that the dengue virus even originated somewhere in the Konkan coast or the Western Ghats or some part of Sri Lanka, which is a continuation of the Western Ghats. So these tropical rainforests are abundant source of all these microbiota, which can spill over at any time, and that is the one that offers biggest challenges in Kerala. Then we need to mitigate these problems. We need enhanced and persistent surveillance. Which is resource intensive, and also a strong political will is required for this. And we need to have systems for early detection and diagnosis, and as accurate as possible, as sensitive as possible. And efficient vaccines and antivirals, and definitely an antimicrobial stewardship, prevention of human man-animal conflicts. That is more interesting. And we were talking that humans are going into the wildlife and getting these viruses. Now situation is changing. Animals are coming into the human population. Maybe that will also lead to a spillover infection. So we don't need to go into the wild and get this infection. While in the periphery itself, we can get these spillover infections. And definitely whatever we could do to mitigate the climate change conditions, and that is also important. Now, let me, before going into some of the basic details on how to get this preparedness, pandemic preparedness. See, usually we do the laboratory diagnosis of infections in two ways. The conventional way was the serology, blood was everything. You take the blood sample and look for antibodies or antigens and have all these tests done. But when this molecular diagnosis came, it is a pathogen nucleic acid detection, that is directly antigen detection. So blood is not the panacea for every diagnosis. You need to have specific samples depending on the disease. So the sample collection discretion is important. So those people who are in the healthcare system, they should apply this discretion in getting the sample so that we can have an early diagnosis. And there are targeted approaches and non-targeted approaches. So most of the time we do is a targeted approach, like the real-time PCR based approach or a LAMP based diagnostic approach, where we already know that okay, there is a pathogen we are suspecting, we want to look at that pathogen. So if we are looking for only one pathogen, we will only see if that pathogen is present or not. But when we need to have suspicion about other pathogen, we need to go for the alternate system like multiplex diagnostics, which is the thing that is coming up and which is the thing that is required for a pandemic preparedness. So the lab on a chip concept, where at a time we can detect large number of pathogens, as many number as possible, or even without any bias for any pathogen, a non-targeted approach. That is a metagenomic virus discovery, where we apply the new generation sequencing system and look for multiple pathogens which are unknown at the same time. So definitely this non-targeted approach is going to be extremely costly, and it may not be routinely used, but at some point, which is going to be a very important component in the pandemic preparedness, where we are looking for unknown diseases, new diseases spilling over to the population. So that is the time when we have to go for the de novo virus discovery approach. Now, at the government level, the national level, there have been a national One Health mission that has been set up for the pandemic preparedness. And all the major agencies and institutes in the country has been brought in the umbrella of this to coordinate the activities to support and integrate all the existing on health activities within the country. And there have been a center for on health in the NCDC in New Delhi. Correspondingly, Kerala government has also started a center for on health in Kerala. And fortunately, we have Dr. Anish with us, who is the director or the nodal officer in charge of that center. He will be maybe mentioning about what he is doing there. And we also have an institute that has been set up at Nagpur, which is an on health institute, which is coming up, which will be looking at the problem, the on health as a priority. And we also have academic courses like the one which was offered by the Kerala Veterinary University long time back on health. So there are multiple activities happening with the stress to on health within the country. And interestingly, or more fortunately for us, the Kerala government has been very proactive in this, and they have set up this Institute of Advanced Virology, from where I am. So where we are looking at on health as one of the priorities that we are looking at. Now, this institute has 14 BSL-2 laboratories, which is, out of that, 8 laboratories are completely functional, and all the other 6 laboratories are getting ready. And an upcoming BSL-3 and a transgenic animal facility, a core instrumentation facility with the state-of-the-art equipments for all the virology-based research that we are doing. And also, we have an advanced molecular diagnostic facility, where we have around 80 to 85 parameters, 85 viruses that we are detecting. So we go for a syndromic approach. We have respiratory panels, neurological panels, enteric panels. So even though the doctor says you look for SARS-CoV-2, see, in this particular case, it was a respiratory, this is a result that we have given for one patient. You can see 19 parameters we have tested. And this was actually a respiratory sample. Maybe the doctor would have asked for a SARS-CoV-2 testing, but we could see adenovirus in the sample. Suppose we are testing for SARS-CoV-2, maybe we would have simply said that, okay, this is negative. And many of these clinical samples, when we do this kind of syndromic testing, we don't pick up any viruses. And we know that this is sent to us by a clinician. He has suspected some infection. So we should do a metagenomic virus discovery, so that even if there is an unnoticed virus in that, even which we didn't think or the clinician didn't think, if something is cryptic in that, we should be able to pick it up. So we have pooled samples analysis that we do every week. All the negative samples, we pool it, and we have already done some 20 pools right now to look into for new pathogens. Fortunately for us, or for all of us, we could not find any completely novel pathogens. Mostly they were bacteria or bacteriophages which we could pick up. But this is a process that we are continuing, so that at some point we will be able to pick up new viruses and new pathogens from this. So this is one of the approach we are doing for pandemic preparedness, and we are also supporting the public health surveillance activity. We have established bioassay facility, especially a flavivirus panel, where the cross-reactivity of this flavivirus is a major problem during the surveillance and studies, and we have BSL-2 based bioassays. Conventional assays, if you are doing a print assay like plaque reduction utilization assay and all, it takes around 6 to 8 days, and this is a 24-hour assay, so that we can overnight we can get the results. And we are also into development of monoclonal antibodies, and against Nipah we have started, against dengue, Zika we have started monoclonal. So these are all measures to support the tackling of this One Health problems in the state. And this is our institute, which you could see there are 2 big buildings which we have been made it completely functional. And as the title of the symposium or the seminar goes, One Health, all for one for all. The Virology Institute stands for supporting this. And thank you for this opportunity, and good luck for the program.
Let me at the outset thank the organizers for giving me this opportunity. Dr. Sahadullah, who is the chairman of KIMS Hospital, was supposed to talk. Unfortunately, he is not available and is out of town, so I apologize on his behalf. But as a clinician and as a transplant physician, many of the factors that affect human beings as a clinician, and really affects me and my patients. So I'll be presenting as Dr. Sreekumar presented the lab aspect of things and the wonderful work that he's doing. I'll be presenting the sort of the clinical aspect and what really happens at the other end. So coming to the Kerala model of health, we all know that it has been described as good health, which is based on social justice and equity. And why have we achieved this is because of the high literacy rates, the women empowerment, the low maternal as well as infant mortality. We know about 100% infant immunization that happens, and decreasing vaccine preventable diseases. And this has been achieved with the constraints of low income and low per capita income. But we really are shifting into a new epidemiological model, the new Kerala model, where we have a high morbidity rate with low mortality. So we see our hospitals filled with patients. We have a government system that is breaking up because of the load. We have both communicable as well as the non-communicable diseases, which is increasing. We know that India is becoming the diabetes capital, or probably has already become the diabetes capital of the world. And Kerala is strongly contributing to that. And similarly, we have a high incidence of coronary artery disease, and coronary artery disease is coming at a younger age in Kerala, and that's what we see very commonly in our hospitals. And you have the newer, as Dr. Sreekumar was mentioning, the emerging as well as the re-emerging infections. And the cost of healthcare is something that we also need to discuss and bring it into the discussion of One Health. One aspect that I also want to discuss is why is Kerala at risk? Because there is a high population density, there is a significant international travel, there's a large population of non-resident Keralites, you have an aging population, which is a demographic shift that we are seeing, and there is a large number of people who are over 45 who have associated comorbidities, and also there is a large forest cover. And there are other causes also, like the influx of migrant laborers that is happening from, and they bring in diseases. You have rapid urbanization, what is known as the urban sprawl effect. That basically means that you see Trivandrum was still Srikaryam or somewhere some years back, and now you have Karakutam, which has been encompassed into Srikaryam, and that sort of a culture of Trivandrum is being brought into Karakutam, and you see half of the businesses that are in Karakutam actually eateries, and that sort of a culture has now come into Trivandrum, and really is affecting our health. And you also have a very stressful lifestyle. You know that everybody has a stressful lifestyle, and Kerala is one of the biggest or the largest states that has the highest suicide rates. So that is also one aspect that we really don't give much importance to, but is part of One Health. And if you look at emerging as well as the re-emerging infections, I'm not going to go into the details of what Dr. Sreekumar already mentioned, but one aspect from a clinician's perspective is what I'll mention is that What we are seeing is a shift in terms of the clinical presentation of disease also. So that might be because of climate change or other reasons. But previously, if you say, when I was a medical student, I used to see leptospirosis as something that affects the kidney as the liver. As a nephrologist, I used to see that. But now, it is not kidney and the liver that is affected, it's possibly a respiratory syndrome. And most of these patients are now on ventilators, have become very sick and die very early. And they don't really have a renal failure. So why is that happening? And I was talking to Dr. Sreekumar about it, and he is saying that you probably are not treating leptospirosis. It could be actually hantavirus, and we don't know about it. There has to be a collaboration between the clinician and the researcher, and that is where the One Health part actually comes in. Similarly, we have Zika virus. We had an outbreak which was actually first detected in our hospital for the state. And we had a large number of young patients who came in with muscle pain, and very rapidly actually they deteriorated, went onto a ventilator and died with significant shock and symptoms of shock. And we were not able to know what was happening initially, and it is only after many patients died we suspected that this could be something that is not common in our state. And an institute of virology like we have in close by, I don't know whether we could have used this facility at that time, but probably we should collaborate with people like the scientists that we are talking about, and not only from the Institute of Virology, but other centers also, even the Rajiv Gandhi Center, and collaborate in terms of what needs to be done for these patients. So we have traditional zoonotic diseases. We also have scrub typhus, a big number of scrub typhus, which is also having a sort of a different sort of presentation now. So 3 diseases an example, but there is a significant change in the clinical presentation of diseases is what I wanted to bring here. And One Health issue, obviously it has so many parameters to it. I'm not going to go, it has been discussed threadbare for the last couple of days. But is One Health the solution? Are we looking at just silos? I think in the last session there was a discussion about war, there was a discussion about climate change. And we really have to look at One Health in an aspect of whether we are providing universal healthcare to our patients. Is it possible? I think that discussion also needs to come up. It also has to be discussed in terms of social determinants of health. It is not that you just discuss One Health, one conference is over and leave it at that. You really need to bring in universal healthcare. And the economic aspect also. Do we in Kerala have an efficient health model? The answer is no. If you look at the Kerala model, it is actually known as the Shimasko model, if you know about it. It was actually brought about by the system which was there in the Soviet Union, the erstwhile Soviet Union. And we have the large sort of publicly owned medical facilities with salaried health workers who do not have sort of a complete responsibility of that unit. And there is a high degree of government administration. I think that also has to be brought in. We see on TV all these politicians running into our primary health centers and disrupting the work there. So that probably is not acceptable, and that is not something that we should, as healthcare workers, would be acceptable for anybody for that matter. And if you look at out-of-pocket spending, that also has to be looked at. Kerala spends around, the people in Kerala spend around 70% of the healthcare is out-of-pocket, which is not something which is acceptable in the modern world. And also, if you look at universal healthcare, if needs to be provided, we just need around 2,500 rupees per capita, but Kerala spends around 9,800 rupees per capita, and still we are not able to provide universal healthcare. So what I'm coming to is we need to actually encompass all the parameters. It's not One Health alone. It really has to encompass the social determinants of health, the universal healthcare, as well as the economic aspects of health, and then only we will be able to take the state forward. And that is one aspect of volume-based care that we give now. We just want to look at the number of patients that we have treated, but we are really not looking at whether we are giving quality of care and what the outcomes are. So really the model has to go into a value-based care, and that is what it has to change over the next few years. And I think this is a very good forum to initiate that discussion. Not only value-based care, but something known as managed care, where we focus on preventive care. But I think that is a discussion for another session. And if you look at coming back to One Health and what progress we have made, I think it was discussed that we have a center in Wayanad called the Cohort, the Center for One Health Education, Advocacy, Research and Training. And we have the Kerala antimicrobial plan. I'll come to that a little bit. There have been other sort of gains that we have made, the implementation of the One Health plan by the government. And this is the Cohort Center for One Health. This is from their website and they are doing excellent work in actually conducting various activities involving the government as well as private organizations, and that needs to be encouraged. This is the Kerala government guidelines that came out in 2022, and there is some fund allocated for it, but we really need to have more fund, and that needs to be taken forward. And we have the CARSAT, which is the Kerala Antimicrobial Resistance Strategic Action Plan, which was started in October 2018, which is the first actually a national level antimicrobial sort of a resistance plan which was brought about in India. And if I go back, actually it was started by our Honorable Chief Minister Pinarayi Vijayan along with a representative from WHO. And if you look at the antimicrobial stewardship program that Kerala has done over the years, there has been multiple levels to it, but one program that should be promoted a lot is the Operation Amrit, which is antimicrobial, basically ending the over-the-counter sale of antibiotics. Even yesterday I could see that one person actually came to a medical store and bought Augmentin, which is amoxicillin and clavulanic acid, and just left. Unfortunately, nobody asked for a prescription. The person did not ask. This is in Medical College Trivandrum, just near Medical College Trivandrum. That is not acceptable. If you have a program that has to be actually, there's some follow-up on that, and there has to be some surveillance as to whether these programs are actually working. And coming on to what at a private hospital level, I think there is some success we have achieved. There are other hospitals and other government centers which have achieved better. But we have taken the core at KIMSHEALTH from the WHO manual. And the important thing is actually the help from the leadership. Dr. Sardala, even in 2002, he actually had given us an impetus into actually starting the antimicrobial stewardship program. We have progressed over the years. We have brought in some KPIs, which is the key performance indicators in terms of AMS. And finally, we have looked at our successes in diagnosing Zika virus, first time in the state, as well as digitalizing the antimicrobial stewardship program. So these are some things that we have implemented, and in a small way these are important because we need to have different aspects of change, and the most important thing is the behavioral change that needs to come in. The knowledge aspect is very, very easy. You can educate anybody. It is a low-hanging fruit, so to say. The attitude change is brought about by involving the physicians and all the stakeholders. And then lastly, you have to bring in the behavioral change that happens. But there are a lot of aspects to the behavioral change. All these things are important, but importantly, you need to actually have the trust of the people who actually do the work. So there might be some factors that might not be applicable. I'm sure that one thing that is mentioned is linking it to appraisal. That would not work in a government setting. I think you'll have a huge hue and cry about it, but at least in our hospital, we are able to sort of link it to appraisal to a certain extent, not to a complete extent. So that aspect is there. So we need to sort of look at which hospital or which institution working in and personalize that for that institution per se. And how did we do it? I think I'm not going to go into details, but we involve the pharmacists, the nurses, as well as all the clinicians, and we are able to bring about a change in terms of what can be done. The future in terms of antimicrobial stewardship is not antimicrobial stewardship alone. If you look at antimicrobial stewardship, it actually is the right interpretation of the lab test, the right antimicrobial at the right time. But it has to be linked with diagnostic stewardship also. That is the next step we need to go. It has to be the right test for the right patient at the right time. So I think we need to integrate the sort of AMS, the antimicrobial stewardship, along with the diagnostic stewardship, and then only we will be able to go forward. And for that, I think collaboration with institutions like the Institute of Virology and similar institutions is extremely important. I think developing core competencies for Kerala is extremely important. We need the skills, we need the values and attitudes, and we also need the knowledge and awareness. And we need to communicate, we need to collaborate, we need to bring in the capacity and also coordinate with different institutions to bring in success for the One Health program. And I think for God's own country, if we have to remain like that, then the God has to be its environment, its animals, and its people. Thank you. Thank you for the patience.
But infectious diseases are very important, because if you may be knowing that US government was shutting down all funding for infectious diseases by early 21st century. But when COVID-19 has struck, then the whole change or limelight is actually going for COVID-19. So that kinds of a situation is there because of emergence of disease. For example, if you consider Nipah killed hardly 20 or 25 people in Kerala, but whenever there is a Nipah strike in Calicut, people of Trivandrum will stop eating fruits. So that is the burden of infectious diseases that is going to happen in socially as well as epidemiologically. So in this small session, I am trying to discuss some very key points about the epidemiology of infectious diseases in Kerala in the context of One Health. We cannot discuss the whole things because I will choose maybe 2 or 3 diseases. This is a very famous picture published in Nature, and you may be seeing that there could be 4 different types of large outbreaks of diseases. What you are seeing in the left uppermost corner is zoonotic pathogens, and the right one is zoonotic pathogens from non-wildlife. If you just look into Kerala's epidemiological situation, Nipah or KFD is something in the category A, and maybe brucellosis is in the category B. All these things are becoming endemic in Kerala. And C is drug-resistant pathogens, where AMR is very important, and D is vector-borne diseases. And if you closely monitor this picture, you can see that Kerala, especially the Western Ghat, is hotspot for A and D. That means if you identify 15 different places in Kerala, in the world, where there is hotspots for these diseases from wildlife or from vector-borne diseases, you will identify Western Ghat as one of the hotspots. So even we can expect another emergence of a pandemic from this particular region. So that is the importance of our land in the context of emergence of diseases. So I will discuss 3 diseases. So we have got endemic diseases for the state: leptospirosis, dengue, hepatitis A. You can include scrub typhus. All these things you may be familiar with. Leptospirosis is elipeni. Scrub typhus is chellupeni or chellugadipeni. Dengue and hepatitis A is manyapitam. And endemic diseases in some pockets of Kerala, and we can expect these things to be happening in anywhere in Kerala in near future. It is leishmaniasis. Leishmaniasis is otherwise known as karimbani. Sometimes you may be knowing that. Malaria is again becoming endemic. And West Nile fever, it is actually a hot topic nowadays that we know. And we have got emerging diseases of pandemic potential of our own. That means Nipah. You may be knowing that in the world there are only 2 places where we identified the circulating Nipah virus that can create a pandemic. That is, one is Bangladesh and second one is Kerala. And we have got Kashinur forest disease reported from our 2 districts, that is Wayanad and Malappuram, for the last maybe 10 years. And we have got now the high infectious avian influenza is also circulating. We may expect a human case maybe in near future, because that much burden is there in Alleppey and Kottayam districts. So leptospirosis, we have somewhere around 5,000 reported cases every year. It may not cover the reported cases from private hospitals. So it is entirely the government hospital, and it has got 10% deaths. And there is a peculiarity of leptospirosis is we report more deaths in probable cases than from confirmed cases. It is a very peculiar disease where you are reporting more death in suspected diseases than from the confirmed disease, because that means we are not getting enough time to confirm it. The patient is coming to hospital, and within 1 or 2 days the patient is getting died. So we were discussing, Dr. Sreekumar and I was discussing in the portico, and we were thinking that some other diseases may also be there, just like Handa virus, that we are not aware. So Kerala is a very conducive environment for leptospirosis. Once we thought that leptospirosis is transmitted by rats, that is why the name Elipeni. But now it is more and more evidence is there that it can be transmitted by cattle, it can be transmitted by dogs. We have got many stray dogs there in the streets, and the amount of urine that is produced may be more than that of rats. And the real culprits may be stray dogs, may not be rats, that we do not know. This is the data, the leptospirosis cases reported in medical colleges of Kerala in 2nd September of 2018. The importance of 2nd September is, it is just 2 weeks past from the peak of the flood. The top raining happened in 2018, was the previous day of the Independence Day, that is 14th August. And after 2 weeks, we were we were expecting or we were seeing large number of leptospirosis cases in Kerala. So it is a disease which is it is very much related to rainfall, and you are experiencing a heavy rainfall in the outside. You have to expect a peak of leptospirosis in Trivandrum maybe after 2 weeks. So that is a pattern, and poor people are getting exposed because it is largely a disease which is there with exposure to contaminated water. So that is a very important fact that we have to think. This is data. Here in this work also Dr. Sreekumar is involved. We conducted this work in 2011. It's actually a slightly old data. But you can see that two things you can make out from this data. One is in the leptospirosis cases in Trivandrum is highly concentrated to the corporation area. Maybe because of contaminated water and all other things. Second one is it is highly related to water bodies. So preserving your water body is very, very important to stop or to prevent leptospirosis. Even the clean Killiyar project of Karakulam Panchayat was end up in a large number of, reduction in large number of leptospirosis cases. So the rivers are very, very important. Maybe our Parvati Puttanar may be a river which is contributing to large number of these kinds of diseases among people of poor segment of people here. So if you just go for leptospirosis, reviving water bodies is very, very important, as it is an august audience, they can influence policy. So you have to think about reviving water bodies. Risk perception of the community is very, very important. If you are exposed to contaminated water, you can be exposed to many other diseases, not only leptospirosis. Now we have got a case of Naegleria fowleri in Kozhikode, brain-eating amoeba. It is because of exposed to water. So now swimming in swimming pools are actually healthy than swimming in local ponds. You may be having a nostalgia in swimming in local ponds, but you can get so many diseases from there. So another pattern that you have to note, if you look at the hepatitis A outbreak of Kerala, the hepatitis A has shifted from the urban area to rural area. Now you are getting actually a good quality drinking water because of corporation is supplying at least chlorinated water. But in rural areas, we think that the water available in the water bodies are good, but they are polluted. So urban people are consuming good quality water and rural people are consuming low quality water. So hepatitis kinds of diseases are shifting from urban area to rural area. So safer handling of animals is very, very important. You have to, maybe people handling cows and all other things. Then another thing that we have to think is controlled chemoprophylaxis, because people think that giving doxycycline prophylaxis is an answer for leptospirosis outbreak. But doxycycline prophylaxis can add to the antimicrobial resistant burden in Kerala, and even our antimicrobiogram now shows that significant resistance against these antibiotics. So this chemoprophylaxis using antibiotics is not a good strategy. Rather than we have to prevent infections, maybe using personal protective equipments and other. So leishmaniasis I will go through because we don't have enough time to discuss all these things. So this is a paper, new focus of cutaneous leishmaniasis in India. It is published that Nilambur is in Malappuram district, has got a pocket of leishmaniasis. Leishmaniasis, you may be knowing that it is better known as Karimbani or Kala Asar. Kala Asar, the word meaning is Kala means black and Asar means fever. That is why we Malayalis tell it is Karimbani. So this is another paper, and you can see my name also in that paper. And it is a focus of leishmaniasis in tribals of Kotur, that is in Trivandrum. So some diseases, these emerging diseases are highly localized to certain communities. Tribal people, if you look at KFD, it is localized to tribal people. If you look at leishmaniasis, it is there in tribal communities. If you look at malaria in Kerala, they are localized to the guest workers. If you look at filariasis, that is also. So these communities are very, very important. And if you are not able to prevent infection in these communities, these can be spread to the population. So this is the lesions. This is a skin manifestation, but in Kerala, it is a peculiar feature that the same agent is causing the skin lesion as well as the systemic disease, which is a life-threatening condition, that is Kala Asar. And this is the insect that is sandfly, it is not mosquito, it is sandflies are transmitting Kala-Azar. And here you can see that Leishmania donovani is the agent for causing the systemic disease, the serious disease. That is causing cutaneous lesions or dermatological manifestations in Kerala. That means same agent is causing both cutaneous manifestations and systemic diseases in Kerala. And so many scientists believe that it is tribal people are affected, that is why it is limited to the cutaneous manifestation there. If this particular agent is coming to affect the local community or general population, the more number of systemic diseases you have to expect. So many papers has come out from this, and I missed one paper which is showing that dogs can act as a reservoir. So these diseases, dogs can act as an intermediate between human beings to transmit this disease. Again, our stray dog menace is actually having this kind of an impact. So again, we have to address the social vulnerability. You have to limit the disease in the social sectors, and if you are able to prevent infections in that particular societies, just like tribes, you can prevent infections coming to the local population. And we have to go for the active surveillance of cases, and we have to build more diagnostic and therapeutic facilities. When we were discussing with doctors, even doctors are not able to diagnose the Kala-Azar. It is a very, very interesting fact that even though we are at risk of Kala-Azar, people are not, our doctors are not efficient to detect the blood picture of Kala-Azar or the picture in the Praveen biopsy or bone marrow biopsy. Often they refer these people to RCC or some other centers for suspecting cancers, and later they are diagnosed as it is leishmaniasis. So we don't have the capacity to even diagnose. So the training and all other things are very, very important. And the last one, Nipah. Nipah might have been discussed so many times in this forum, so I am not going to detail. We have got 4 outbreaks starting from 2018 and 2023. The last outbreak is a landmark thing because we reduced our case fatality to 33%, 1/3. So we tried different antivirals, and people consumed or people taken antivirals were saved. Or now we have got more evidence that even people can be saved if you have got Nipah, if you are able to detect early. And you may be knowing that Kerala is the only population or only health system where now able to find out Nipah in the active phase itself. In Bangladesh, most often Nipah is found out after maybe the death of the patient. But now we are the community, they can, because of the maybe a better health system, we are able to find out cases early and we can prevent deaths in Nipah. This picture you can see in the left hand side is the different places where we were able to find out Nipah virus or antibodies against Nipah virus in Kerala from 5 districts, because we conducted the analysis only in 5 districts. The other 9 districts we didn't get any analysis, and we think that we are Nipah free. But wherever you conducted the analysis, you found that our bats are infected with Nipah. That means there is a high possibility that in every places in Kerala, the bats may be infected with Nipah. And the right hand side, you can see a small graph there, and you can see that in 2023, the serological positivity in virus was increasing from February to September, and in September we had an outbreak also. So there is in Nipah, there is a huge scope of analysis and research, and Government of Kerala has came out with a Nipah Research Center, and I happen to be the nodal officer. So we are trying to build on these kinds of things. So Nipah is a priority because it is a paramyxovirus. Paramyxovirus can have different intermediate hosts. In laboratory, Nipah can infect any animals. If you expose them to rats, if you expose the virus to dogs, cats, any animals can act as an intermediate host. So that is a very big issue, that an intermediate host or something like an animal can act as a medium. They can get the infection from the bats and transmit to human beings. And there is high human-to-human transmission is there. And if you look at the Nipah outbreaks in Kerala, 75% of people got infection from hospitals. So the infection control facilities in hospitals are very, very important. This picture you can see that This is a published paper on 2018 outbreak. And you can see that how this disease is spread in hospitals or in narrow corridors. Here you can see in the left-hand side is the Taluk Hospital, Perambra, and you can see that ward, so many people were affected in that ward. In the middle picture you can see it is the CT room. That's actually corridor of CT room of Calicut Medical College, and you can see that so many people got infected from there. So our hospitals structures are very important because this disease because these people will come to hospital, and hospitals can become epicenters. So another social change should also happen because you don't have to use hospital as a social space. Please don't go to hospital unnecessary. Don't think that just like going to a marriage function, don't go to hospital if your friend is admitted there or not. Let him come to home and you can visit. Otherwise what will happen is you may get diseases from hospital. Sometimes you will give diseases including the agents of antimicrobial resistance to the hospital environment. So better avoid using hospital as a social system. Okay, again definitely we have to think about solutions. As I have already mentioned, this community has to come out with some kind of a solution for these things. I just discussed a tip of iceberg that we are facing in the infectious disease spectrum, and there are much more to discuss. And definitely the building community's resilience is very, very important. Research to address maybe knowledge lacunae. In Nipah, the encephalitis ARDS surveillance is very important. ARDS means acute respiratory distress syndrome. So if you look at the emerging diseases, these diseases are presenting with a peculiar symptom, that is neurological symptoms. And if you have got a fever with a neurological symptom, it is an alert that you have to think about different possibilities that can range from Nipah to maybe West Nile fever. So environmental risk factors should be addressed, including deforestation and all other environmental damages. So that is from me. Thank you.
As a token of our gratitude, we would like to present you with a certificate from Grow Trees, MR from SBI. If you would please present the certificate, Mr. Rajiv Chandran, Calculus Network. Kindly come up on the dais, present the memento to Dr. Praveen Murlidharan. And Mr. Rakesh, Canara Bank, if I may have you presenting the certificate to Dr. Anish. KIMS, SBI, Calculus Network, Canara Bank are platinum sponsors. We're very grateful indeed.